Hey everyone, welcome to our 13th live stream. For those who don't know me, my name is Julesy Capon, and I am a longtime patient of Dr. Jemsik here at the Jemsik Specialty Clinic, and I'm also a Lyme literate psychotherapist. And so I provide individual psychotherapy for people of all ages. And I also want to remind everyone that I run a few free online support groups. The first one is for adults ages 18 and older, and we meet the first Tuesday of every month. And again, this is virtual and it's completely free. And I'm excited to announce a new group that I'm starting in 2 weeks, and that's for parents who have a child or children with Lyme disease and are looking for some extra support. So if you're interested in that, you can find more information on my website at Capon Counseling, CAPON counseling.com. And today I'm so excited that we have a very special guest, Dr. Robert Bransfield, a world-renowned Lyme literate psychiatrist. And today we're going to be talking about the neuropsychiatric symptoms of Lyme and associated diseases. So before we get started on the awesome questions you guys submitted, we're going to introduce the two doctors we have here with us today. So we'll start with Dr. Jemsik.
Good morning, everyone, and thank you for joining us. This is indeed an honor. We're in my office, Jules and I. Dr. Bransfield's in his office on the water, so he's going to throw a line in the water pretty soon, I think, as soon as we finish here. But he's got a better office than I do. This is our 13th live stream in roughly 14 months. They're an hour each. We try to keep them as educational as possible and as least political as possible. We really appreciate your following us and asking provocative questions. And today we are honored. This is the first time we've done a Zoom, but Dr. Robert Bransfield, who's a long-term acquaintance and a very good friend of mine, is with us. And he is an esteemed psychiatrist, expert in neurophysiology and effects of psychotropic medications, past president of the New Jersey Psychiatric Association, past president of ILANS, renowned lecturer overseas, and especially renowned and author with a candescent reputation for productivity. He is without doubt the most productive and insightful author in this very, very important field. And so it's indeed an honor. So we are going to focus, given the opportunity to have Dr. Bransfield, we're going to focus on neuropsychiatric aspects of Lyme borreliosis, which of course are prominent and varied. Dr. Bransfield.
Thank you, Dr. Jemsik. And thank you for the opportunity to be here and a nice introduction. And it's always good to kind of share information about this. I realize as a psychiatrist, I've been dealing with Lyme disease cases from the day that I began my psychiatric training. And looking back, I'm sure I was seeing neuropsych Lyme cases 50 years ago, and but they weren't called that then. And I've been recognizing that there are Lyme cases and working with it a lot over the past 30 years, wrote some journal articles. And basically, if people were good at diagnosing this, preventing it, diagnosing it, treating it early, treating it effectively, I wouldn't be needed. I wouldn't be needed to be seeing all these Lyme psych cases. But because there's so many failures of the system and because there's misinformation out there, a lot of people are given one dose of doxy, or they miss the diagnosis, they're not adequately treated, and then you see the long-term manifestations. Average person I see is going 10 years post-treatment, but some are shortly after infection, and some could be 40 years after infection. It's a big range, but you have to be able to connect the dots here.
All right, we're going to jump right into the questions. So the first one for Dr. Bransfield and Dr. Jemsik, if he wants to jump into, is what are the most common neuropsychiatric symptoms of Lyme or other tick-borne diseases? And how long do they usually last? Are they permanent even once a patient hits remission?
Well, usually you get, for instance, the skin things first, and then the fatigue and those, the cognitive and the brain fog come fairly early, but then the psychiatric things are later, usually a few years out. So you can look at it first, the vegetative symptoms. You can break the brain down into part of the brain that's what we call vegetative, and that has to do with sleep disorders, eating, libido, temperature control. You see abnormalities in that area. But then you have cognitive part. That's the outer layer of the brain. We call it the cortex. And then the middle layer, which is the limbic system, which is the emotional part. It affects all three. So when we look at cognitive, that's a part of neuropsych, you can see slow processing speed. It's like an old computer that takes forever to process information, or like a Peanuts cartoon when the adults are talking. It's wah, 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 wah. So that you can't digest information fast enough and you can't organize it fast enough when you're communicating. And so that's processing speed, attention span, sensory overload, where you get flooded. It's just too much. And then memory problems, trouble concentrating, organizing. And then also the emotional part can be low frustration tolerance, irritability, depression, anxiety, social anxiety, panic attacks, obsessive compulsive disorder. Intrusive symptoms are a big thing that people don't understand well, where there's this intrusive thoughts or image. And then once it comes out of nowhere, people are kind of surprised and where did that come from? And they get very upset with that. Mood swings, anger, outburst, and everybody's a little different, but you see these patterns that go repeatedly. And fatigue is a big thing that goes with it. So it's that cluster. And then how do all these symptoms feed on each other and interact is the big question. And then we have to look at how they fit together. So that's the average case that I see. They have that mix.
Right. I'd like to just say there are several fuel sources, and one of which is you can't control your life, or you feel like you can't communicate. And that's devastating to people. Self-esteem is devastating. People want to be able to control something. I have a 4-floor condo, mood condo. And I'll just say that the first floor that I've noticed over the years that on the first floor, we have irritability, and everyone is irritable. And so they're just unhappy and they're irritable. And then it gets worse and gets in some of the more advanced psychiatric issues that Dr. Bransfield just mentioned, but everybody's irritable.
That goes with the low frustration tolerance that a lot have. You have an unrealistic expectation, which is really a realistic expectation for a normal person who doesn't have Lyme. When that isn't met, you get frustrated, then irritable, and then it can accelerate the temper. Okay,
Right.
sorry.
Thank you.
No, you're good.
Right.
Next question is, I've had genetic testing done to see which SSRIs are best for me and none are compatible. What should I do? Dr. Demczyk, do you want to start?
Well, traditionally in our methylation pathway, we look at MAO-A, which so there are substitutions in the genetic code, and if you have one, it's called heterogeneous. If you have two, it's called homozygous, and that just means the enzyme's not working at full capacity. So even if you have two substitutions, it may work at 25% is still working, and that's fine as long as it's not stressed. And we're all imperfect, trust me. We all have multiple substitutions. The bottom line is, does the drug work or not? And, if I have a substitution, I don't worry about it if I feel like that, I just use less drug in a lot of cases if I feel like it helps. Sometimes it's still too much for that individual. And so I will go ahead and defer to Dr. Bransfield on this.
A lot of people misinterpret that testing. That testing does not show what drug you should be on. I want to emphasize that point. It only shows whether you might need a high or low dose of any given drug. It shows how quickly your body burns it up. And if you're what we call a slow metabolizer, that your body gets rid of it slowly, or if your body gets rid of it fast, then that might determine whether you have a high or low dose. And sometimes that testing doesn't always fit. It doesn't always fit with what I see clinically. So it does not tell you that you can't take these meds. What you should do, I think, if you have Lyme disease, many people with Lyme, when they have Lyme and it's active, they often have a low tolerance for many meds. So you often have to start at a fraction of the lowest dose, pretty much across the board, no matter what testing show.
Yeah, and then later I would love to get
increase slowly. Yeah, go ahead.
Later, I'd like to get some of your insights, Bob, into what the sensitized brain means in terms of neurotransmitters and the effect postsynaptic binding and neural channels, because obviously the brain is on fire.
Mhm.
And you always have the comment, oh, my psych drugs don't work. They work with most people, they don't work here.
Can I ask, when is it appropriate to get that testing done to see which SSRIs are compatible? Is that when all of the other meds have failed and you don't know where to go from there?
I often don't order it.
You don't order it?
When it first came out, I started ordering it, and then I found it wasn't very useful. So
Okay.
I think it's sort of an unnecessary expense,
Mhm,
and
Right.
it's
We're also talking about pharmacogenomics,
mhm,
which is how the cytochrome system handles these things, which, I get mixed signals on those too. I mean, because there are multiple enzymes that control the degradation or inactivation of a particular molecule, drug, and you get some of both, you don't know which is more prominent. So I don't think it's terribly useful.
see, here's what happens. Like a lot of times when you get Lyme, because as I said, it affects what I said, vegetative symptoms. That's a brain stem, that inner part of the brain. Often one area is that people have low body temperature. And when you have low body temperature, when it's reduced by even a degree, so a person's body temperature might be 97 instead of 98.6, then invariably meds are metabolized much more slowly, and you become less med tolerant when your body temperature is lower. And that may be a bigger consideration. What that testing shows is what we call the cytochrome P450 system. And for instance, there's 2D6, 3A4, and those are the more common pathways that for many drugs, but not all drugs. And you could be a rapid or a slow at breaking down drugs that go through those pathways. And I know, look at how you do with drugs that are broken down in those pathways, what dose you need. And there's a big variability. There's 100-fold variability in the dosing you need for the same drug in different people. So you just have to be aware that some people are outliers. Some people need super low doses and some people need super high doses. And as I said, it's 100-fold difference with some of the patients I've treated.
And as clinicians, we always start low anyway. We start low.
low dose on the dosing?
And we don't order the genetics on everyone, that's for sure. I would order the genetics, not just for handling psychotropics, but for other considerations as far as diet and so forth, on our most complex patients, but not on everyone.
All right, next question for Dr. Bransfield is, intrusive thoughts often keep me up at night. What are the best medications to help with that?
Well, there's the one medication is topiramate, Topamax. Another is prazosin, and another is Periactin. Now, Topamax is a anti-seizure med.
Mhm,
That the problem with Topamax is that you don't want to take it if you have glaucoma or kidney stones, and it can give brain fog, which people with Lyme already have. But if you take it in the evening, often it's gone by the next day, but you have to see how the person does. Another side effect of Topamax is weight loss. And usually I don't get complaints about that, right? So it particularly reduces carbohydrate craving, which is particularly good because you don't want to have Lyme and be a carbohydrate craver, okay? So when you have intrusive thoughts during the day, but we are active during the day and that can suppress it. But your problem is at night, you have the intrusive thoughts and you don't have any other thing that you're doing that's empowering to neutralize it or anything to distract you. So the Topamax is one I try. The prazosin I often try. The prazosin is a blood pressure med, mini press, and they gave this at a VA hospital and they found that the war veterans had less nightmares about the war when they were on prazosin. And there's 50 blood pressure meds, but this one particularly seems to help that more than others. Now, the problem there can be if you have POTS or orthostatic hypotension, it may lower your blood pressure, but some people tolerate that. But it's like, which side effect can you better tolerate and which one works better? Sometimes I combine them. And, but they do reduce intrusive thoughts. The third one is Periactin, cipraheptadine, which is a antihistamine. And that can sometimes work too if the person can't tolerate the side effects of the other two. Other meds that I sometimes use are Tenex or Clonidine. Those are two other blood pressure meds that sometimes work when those other three fail. You can also use the SSRIs. That doesn't really reduce intrusive symptoms, but it reduces the looping after those intrusive symptoms come to your head. So it's a 1-2 punch. It intrudes and then you loop on it. Why did I have that thought? Where did that come from? It's a thought that I would not normally think of. Why am I having this violent, horrific image or thought? Where did this come from? And now the person can't get over it. So it's the intrusive meds, then the anti-obsessive meds. It's a 1-2 step there.
Is prazosin, or I don't know if I'm saying that right, is that also prazosin?
Yeah.
Is that also used for nightmares?
Yes, yes. So we're basically using the meds that we use for post-traumatic stress disorder. And when you look at this, when Lyme patients, it seems like it's inflammation that affects the temporal lobe. And now the problem can be a lot of Lyme patients get post-traumatic stress disorder from having Lyme disease. It's traumatic when nobody believes you and have all these weird symptoms.
Absolutely.
And a lot of people are traumatized by the healthcare system when they have Lyme disease, and their families don't believe it. Nobody believes it. They don't believe it. Okay. You know, what's happening to me. So it's very akin to post-traumatic, where you get intrusive flashbacks. So you treat it the same way pretty much that you would treat a post-traumatic stress disorder, with pretty much the same meds.
And you're blocking norepinephrine predominantly. So with sleep disorder, I ask people what wakes them up, for example, and if it's an intrusive thought and they're waking up shaking, they've obviously got it's not a pure syndrome awfully, but it's predominantly norepinephrine, or at least that's playing a role. Histamine can play a role, glutamate can play a role. And what else would you say would play a role, a prominent neurotransmitter to disturb sleep that's upregulating and surging? Would you say?
Well, you know, it may be the NMDA receptor, you know, with quinolinic acid, and there's a glutamate effect there. So and invariably the nightmares are the second half of the night. They hit you maybe 3 or 4 in the morning when you're doing REM sleep. You don't have the nightmares in the beginning of the sleep when it's more the delta sleep. It's the REM sleep part. So it's 3, 4 in the morning, they wake you up. And during the day, an intrusive image is really like a daymare versus a nightmare.
That's a good way to put it.
There's not a word daymare, but it's really the same thing. An intrusive symptom is a daymare, okay?
The next question, what are the risks with immunosuppressive medications? My daughter started on Stelara for psoriasis and her Lyme symptoms got worse. So before Dr. Jemsek answered this, I had such a similar experience when I started on Humira for Crohn's disease. I hadn't been diagnosed with Lyme yet. I had symptoms, but I was still pretty functional. My main problem was my Crohn's, so trying to manage that. And when I got put on Humira a few months later was when I one day woke up partially paralyzed from the waist down, and then symptoms progressed to seizures and tremors, and you name it, I had it. But what I assume happened was that suppressed my immune system so tremendously that the Lyme was able to flourish. But Dr. Jemsek, can you explain that better medically?
Yeah, I happen to know the family here, and young lady had to be hospitalized for neuropsychiatric symptoms. So it was profound, debilitating, devastating to the family, and a great concern. She's now doing much better to the point that she wants to get rid of her psoriasis. Well, Stelara and a lot of the DMARDs, disease-modifying anti-rheumatic drugs, are they can be purely immunosuppressive, or they modify the biologics that are modifying, or sometimes monoclonal antibodies that block some of the pro-inflammatory cytokines. Now, our enemy is chronic inflammation, but we need acute inflammation to complete the natural anti-inflammatory or pro-inflammatory effect when we have foreign antigens. And that's why you'll see on the TV commercials that, don't take this if you've had TB, or it may cause this, type of cancer, rare cancer, that sort of thing. And so that's what's happening. Immune system, you put the immune system to sleep. And the number one drug to do that is steroids, the nuclear kappa factor. There's nothing more profoundly immunocompromising or immunosuppressive than steroids. In this case, Stelara is a monoclonal antibody that catches some of the IL-2 and IL, I think 17 antibodies. It's a monoclonal antibody, which means it's a group of proteins that are all look alike and have been produced specifically to be given passively injected every so often, because the half-life is usually 15 days, to block a pro-inflammatory response. Well, in my patients who have been immunocompromised already by this illness and who lose their CD4 counts and CD8 counts and CD3 counts, and who have low IgG, by the way, and this is all connected, by the way. So Lyme borreliosis is complex, and all of its, when I say complex, I'm talking a lot of co-infections, folks, a lot of many other complications. They become immunocompromised, and our thymus is responsible for regenerating those lymphocytes, but the thymus gives out when we're teenagers. So if you have a low CD4 count or CD8, and this is something that's begging to be studied, by the way, just begging to be studied, but it's something we see all the time. We see low IgG, we see low CD4. I did AIDS for 23 years. I see CD4 counts where I think somebody ought to be on prophylactic medication because of HIV complications. But the functionality is different. But the point is, having said all that, I sound like a damn lawyer now, sorry. I said all this to say this. We need our patients to recover. Now, they do recover immunologically in other parts of the immune system, monocyte macrophage, primarily the front end of the immune system, not the back end, which is adaptive. So they do improve. So they do get stronger, no question. But I like, especially if somebody's been on IV, I want 3 years before we start using any kind of immunosuppressive therapy or any kind of other provocative agent, IV COVID vaccine, to be sure we don't destabilize the immune system that is struggling to recover. And by the way, when the immune system recovers in our very sick folks, we need clear path. We can't have consternating issues that are stalling out and dragging on the trajectory of recovery.
Mm-hmm. I took a year off from the Humira when all those symptoms happened, and then I gave my body a break and started Remicade, another immunosuppressant medication, a year later, and the same thing happened. So I don't think a year was quite enough. So I agree with Dr. Jemsek. It needs a little longer than that. But Dr. Bransfield, do you often hear after your patients will start on one of those medications?
Yes, here's the problem. Nobody really gets adaptive immunity to Lyme disease. That's why you get reinfected. So you get the infection, and the Lyme is immunosuppressant, the Borrelia is immunosuppressant. And then you get infection causes immune reactivity, be it inflammation or autoimmunity, and you never get adaptive immunity. And it's that immune provocation that causes the symptoms. Now, the trick is it's good to tweak the immune system, but not to hit it with a sledgehammer. Steroids are a sledgehammer, and some of these newer drugs that are used are more like that. And you have to think of it like a row of dominoes. And, the steroids or these immunosuppressant things are hitting a later domino. You'd rather hit the earlier domino. What's the disease sequence, and how can you intervene if you suppress all the immune system, then the disease is going to get worse, and you're going to, in fact, there's a honeymoon period where it reduces your symptoms, but then the infection is advancing because the immune system is no longer fighting it the way it should. So I think you have to be careful and look at what part of the immune system you want to suppress, and tweak it, don't clobber it. I think that's the key. It's a tricky balancing act. Mm-hmm. And that's a big thing with neurotransmitters, immune transmitters in the brain, which they're two different communication pathways. It's a balancing act. It's just like flexion and extension, and that's the basic anatomy, physiology of the brain. That's one part says, attack, and another part says restrain. You're balancing it. So that's the way to do it, getting the right dose and the timing and not overdoing it.
Mm-hmm. Our next question that came in is about your published studies, Dr. Bransfield. So we're not going to talk about that now, but we are going to post it on Jemsic's social media sites, so Instagram and Facebook. So look out for his studies. All right. Can the COVID vaccine affect mental health in a Lyme patient? Dr. Jemsik, you want to start that one?
Well, nothing in medicine is simple. And to put a blanket over the entire country and say everybody's going to be vaccinated, you're going to be fine, it's just not realistic, because we have all kinds of subcategorizations. not to diminish the severity of the COVID vaccine, I'm sorry, the COVID pandemic, but there are selected individuals who are immunocompromised who I think should be waived from having the vaccine, especially if you have an alternative, which, you know, at JSC, we have an alternative, which is very safe. And Dr. Bransfield is very familiar with hydroxychloroquine, which was bandied about and hijacked by St. Tony Fauci, and ivermectin. And people around the world love ivermectin. In the United States, not so much. So, but there are now some very good studies from the Freedom Group, the flccc.net website, which has all of the articles supporting the use of ivermectin. So I feel very safe prescribing that for my folks, and have very few reactions. The reactions I have are pretty much in people that are pretty naive to therapy and have a lot of biofilm and parasites in the gut yet, and yet those reactions are generally tolerable. Now we have the long hauler syndrome with the COVID infection itself. And I'm not going to get into adverse effects of the vaccine, which I think are underreported. And, you know, they say it's like 0.5%. Well, I must have half of those in my practice because, you know, we get, and so they reported dutifully to Pfizer, to Moderna, to Johnson, JJ. I'm not an anti-vaxxer. I just, you know, if we have an option to protect our patients while they're healing, that is the choice that I would recommend. And the long haulers, and patients will come in and talk about long haulers and what they're describing, and you know, say, "Hey doc, that sounds just like Lyme disease to me," because all of a sudden they got neurodysesthesia, which means, you know, nerve pain. They've got processing issues. They've got brain fog they never had before. They can't articulate. They have pain they never had before. The new headaches included, maybe some body pain and ungodly fatigue that just doesn't go away. And that's called long hauler. And right now they're saying, well, does COVID have extended activity on the immune system and the body? Well, COVID does hit very heavily the brain, the gut, to a lesser extent the lung, but that's its portal of entry, the primary infection, the male genitalia, and many other organs. And so COVID is, you know, capable to do that. But the question is, does the coronavirus cause symptoms that go on for months to years? And I'd like to hear what Dr. Bransfield thinks about that.
All right. It's something I've paid a lot of attention to and given a couple of talks on. How does it affect Lyme patients, first of all? And I've seen three basic effects. One is Lyme patients that are under treatment often do quite well when they're exposed to COVID, because many of the treatments we give for Lyme are protective against COVID, including disulfiram, fluvoxamine, the hydroxychloroquine. Some are being treated with ivermectin for Lyme, particularly the Morgellon patients. So, and many of the antibiotics, it seems like they often do rather well. Now, the patient who has Lyme and is not under treatment and gets the COVID, often I see then a relapse. And then that can be rather bad. Now, the third group that's rather small, but it's kind of interesting, is that every now and then I see some Lyme patients who get the COVID, and then they get a very high fever. And when they have that very high fever, that seems to be almost therapeutic in some way. It goes back to the old concept of the malaria treatment for syphilis. And that group, I'm trying to see enough of these people that fall into that category. Just like every now and then I've seen where someone gets an infected port and they get a high fever, and somehow that high fever activates the immune system and maybe is therapeutic some way for the Lyme disease. That I'm trying to make sense out of. Now, I've also seen where, let's say, some people get the vaccination and then they get a Bell's palsy, or they get some other like Lyme symptom appear. And I think that might be someone that has a latent case of Lyme that's currently not very active, but then I think the vaccine kind of reactivates it. And if you think of it like the long haulers versus chronic Lyme, pretty much the same. COVID has somewhat more pulmonary symptoms, more clotting, but the persistent multi-system inflammation symptoms are really identical, with the brain fog, the fatigue, the cognitive impairments, the neuropathy, they're all very similar. And, and it's interesting that some of these chronic COVID patients, you give ivermectin and the symptoms improve, and some do improve from the vaccination, which makes you think that in those cases there's persistent infection. And a recent study came out just a few days ago showing persistent infection in monocytes. So I think a lot of these so-called post-treatment syndromes are not post-infection syndromes. And probably there's a lot of persistent infection with these chronic COVID patients because there is chronic infection that isn't necessarily recognized. And just like we see with Lyme, and call it what it is. It's chronic COVID. It's not a truck driver's term of long haulers. Okay, that's someone who drives to California. It's chronic COVID. It's chronic symptoms. And just like we have chronic Lyme, they're chronic symptoms, and it can be associated with chronic infection. But at least there's chronic symptoms, not always chronic infection, or chronic relapsing infection sometimes. But I think people are looking at this, and it's shedding light on what we've always been saying about Lyme, chronic fatigue, fibromyalgia. All these persistent immune provocation chronic illnesses are very similar.
I'll just add that this is an important area. So I think that in our population, we primarily historically we discovered that many patients have held on by a thread. They may bob and weave, and so visually I have this idea that there is a thin, wafer thin area between the immune control and the stealth pathogen load, and triggers of any kind can invert that paradigm. And so then the immune system is playing catch up, which is exactly what happens with COVID when it gets behind the adaptive immune system. The second system is supposed to have the sharpshooters with the immunoglobulins and the T cells, as versus the front gate, the innate immune system with monocytes, macrophages, eosinophils. And so as we age, the adaptive system goes down, and then once it gets past there, it plays catch up, elevates PAI, which is a procoagulant, prothromboplastin activating inhibitor, and people clot to death. But the immune system, they're playing catch up, and that's what's happened in Lyme disease. And so if you get behind, then you're playing catch up and making all this noise, and now you've liberated a spirochete, which doesn't have much immune control. And if it's a gentle switch, it may be more gradual, but if it's dramatic and violent, you fall off the cliff. And so I think that I look at COVID as a major trigger, and I look at a lot of our infections as where was the trigger? And they'll say, oh yeah, we had to move, and I was worried about my son who was had broken arm, and I lost my house, and my marriage went bad, and my dog died. That's a big one. And it doesn't take a lot if you don't have the cushion, the immunologic cushion, and that's what I see, a general erosion over the years by these pathogen sets. And then it depends on your lifestyle, depends on the environment that you're exposed to, which is a big unknown, and it depends on your genetic patterns and how well you can enforce control or how well you detox.
Let me just add two comments. I really want to emphasize something that Dr. Jemsek said. The FLCCC is a wonderful group. That's where you go for information, not government websites. FLCCC, these are the doctors that treat these patients 12 hours a day, every day, and they know what they're talking about. They know it's not a backroom bureaucrat that never treats patients that you listen to. It's the frontline doctors. They're like the ILADs or the like the Dr. Jemseks of COVID, okay, that they treat this. And with the immune system too, we just had every 2 years we have an international psychoimmunology expert meeting in Goonsburg, and we just had it this past weekend. And what came up a lot at that meeting was a discussion of adverse childhood experience and chronic stress as something that also provokes the immune system, recognizing that a lot of times these persistent infections are a culprit, but adverse childhood experience, chronic stress, also provoke and keep us in that inflammatory mode. It's the additive effect, it's that balancing effect that often, throws us out of balance and has that triggering effect like Dr. Jemsek's referring to.
Mhm. All right, moving on to our next question. What can be done for severe panic attacks caused by Lyme or associated diseases? I love this question because a lot of my patients describe not just normal panic attacks, these prolonged, lasting for hours type panic attacks. So Dr. Bransford, how do you treat panic attacks with your patients?
Well, when I was taught about panic attacks, they said, well, they're very brief. They're certainly never more than a half hour. They're a few minutes, but they feel like an eternity.
Mhm.
And then Lyme patients would say to me, well, I have rolling panic attacks. They can go all day. And my
Right.
first thought, that's impossible. That's not what I learned. I said, well, that's what I've got. Okay.
Mhm.
And then I kept hearing that from more and more patients. And I thought, well, maybe what I learned was wrong. And what it seems that if you have these persistent panic attacks, if you have a panic attack that lasts more than a half hour, you have Lyme disease, period. Now, maybe it's Bartonella, maybe it's Babesia, but you certainly have tick-borne disease if you have these long, prolonged panic attacks. It's very different than these other panic attacks
Exactly.
that have some other etiology, okay?
Mhm.
And if you look at what panic is, it's your imminent alarm system where there's imminent danger. It's like the fireman that goes down the pole instead of down the steps. Boom, it's fight, fight, flight in a fraction of a second, you're there. And now the meds that we do use that reduce panic attacks in psychiatry in general can work with Lyme. We have the short acting ones like the benzos and you can put it under the tongue to work quickly and that may abort it. But then as soon as the med wears off, you're right back there. But there's certain antidepressants. That's a major part of treatment that some of those block panic. A couple of the SSRIs and a couple of the tricyclics, they can help to block panic attacks. So a lot of times I use those. If it's more starting in the body, sometimes it's the beta blockers that we use. If it starts more with the pounding pulse and that, you have to look at what the sequence is and treat that. But it's a terrible thing to have those unending panic attacks. And I think if you have those long panic attacks, absolutely it's diagnostic of tick-borne disease. It's very specific to it.
You're so right about that. We're taught panic attacks last a few minutes, tops 10, 20, 30 minutes, but my patients tell me they can last all day, even an after effect into the next day. So it's very unusual from my patients that I see that do not have tick-borne illness, that they can kind of power through within 10 minutes. So it is a good way to distinguish whether someone has tick-borne illness.
Yeah, I found that at first, I think it's absolutely diagnostic.
Mhm.
It's an argument is there's no specific symptoms of Lyme disease, but there's specific patterns. But if you look, what are the specific symptoms? One is panic attacks longer than a half hour. Another is migratory joint pain. Another is the bullseye rash. And another is a very late manifestation we don't see much in this country of what we call ACA, acrodermatitis chronicum atropicans. Those are the 4 symptoms specific to Lyme disease that are diagnostic by themselves with no other symptom. But most of the time you make the diagnosis by symptom cluster, patterns of symptoms. But panic attacks is these panic attacks we're talking about, very specific to Lyme tick-borne disease. And we could argue, what is it? Maybe there's some co-infection mix. Not everybody with Lyme disease gets these panic attacks. Why do some people get it and other people not? Now, panic disorder and attention deficit disorder are the 2 psychiatric conditions with the strongest genetic component. Okay, so, and other things have a very weak genetic component. So it's always a gene-environment interaction. And when you look at the environment, a lot of times the environmental triggers are infections and immune reactions from them, such as Lyme disease.
Dr. J, do you have anything to add about anxiety or panic attacks?
Just that we call the amygdala the devil gland. That's the source. And I've always thought that it gets activated. It's just like a red coal at the bottom of the brain. And it's just flooding the body with norepinephrine and possibly other neurotransmitters and overriding the prefrontal cortex. So the patient will say, well, I'm having these panic attacks. I can sort of rationalize that there's nothing to panic about, but I can't stop it. And what happens is that the signaling from the amygdala short circuits or beats the ability of the prefrontal cortex to fire. And it is absolutely part, not in the extreme always, of course, but it's absolutely, anxiety is absolutely part and parcel of chronic borreliosis. People say all the time, I never used to have anxiety. That just wasn't me. And so, you know, we are using CBDs, we're using benzos, we're using some antihistamines sometimes, and we're talking detox, we're using, you know, terpenols and other herbals and that sort of thing to try to calm down the brain. And if you look at our website, we have a stabilization period where, I didn't mention POEMS, but M stands for mood. If mood is not on the playing field, now, Bob, you know what I mean by this. It doesn't have to be perfect. It just has to be manageable. And treatment has to be manageable. We don't expect a perfect mood or perfect sleep or, you know, control of all pain, but the mood has to be manageable because that's a non-starter. If the mood is off the reservation or off the rails, whatever acronym you want to use, or, you know, aphorism you want to use, you can't get that patient better. They just have to be stabilized.
Let me comment about what emotional illness is. Like, for instance, anxiety, we use the word a lot, but what is anxiety? Anxiety is emotional activation you can't channel. So it's like being in your car and you're gunning the engine, but you're in neither forward nor reverse. You're just spinning. So vagueness particularly is conducive to anxiety. Panic would be like, picture, if someone doesn't understand it, picture someone points a gun at your face and says, I will shoot you in 10 seconds. How would you feel? Or you're driving on a highway and a big truck pulls out. It's that sudden surge of imminent alarm that could be fright, fight, flight, any of those three. So that's panic, which is different than anxiety or fear. Now, fear, like, or depression, think your brain is like a gear shift. You should feel depressed when you do something futile, and that makes you pull back and not waste further energy in it. You should feel energized when you're successful. You should feel fear when there's danger. But when we have illness with this immune system altering the way our brain works, then our emotional reactivity doesn't match our current life situation. We have anxiety and fear when it's, or panic when it's not called for, or depression. And we, so it doesn't match, and our ability to navigate emotionally isn't like it is. And then another part of the anxiety is the flooding, the sensory overload, where people are bombarded by stimulation. It's just too much, and that adds to the constant anxiety and irritability that was discussed earlier. Okay.
Dr. J mentioned poems and being mood, one of the major roadblocks to healing. So while we're talking about that, one of the questions is, I recently started treatment, but had to stop due to increased suicidality or depressive symptoms. Do you recommend taking a break when that happens, a break from treatment?
Yes, absolutely. It's and I think what it is if you look at, let's say suicidality, if you are in a state of inflammation, what happens there is there's an increase of a, what we call an enzyme, it's abbreviated IDO. So tryptophan, which is an essential amino acid, should be turned into serotonin and melatonin. That's a good thing. But when we're in a more chronic inflammation state, that chemistry shifts, and we instead end up with what's called quinolinic acid, which is a neurotoxin. And the quinolinic acid on what's called NMDA receptor, that can make us suicidal. Okay, so now when we give a treatment that increases inflammation, and we're killing, let's say, and then we get that inflammatory thing. In the long run, that may be therapeutic, but because you're having a blip, an increase of inflammation, you're having an increase of that biochemistry that makes someone suicidal. There are studies, and that goes along with the reduction of a chemistry of the spinal fluid, which is 5-HIA. People looked at that in the spinal fluid, and they could predict who would be dead within 2 years from suicide by looking at the spinal fluid. So that it's you have a chemistry that makes people suicidal, that is provoked by the infection. But also there's that alienation and that frustration that adds to it. So there's a psychological as well as a physiological thing that makes people suicidal and aggressive. It's a somewhat similar overlap, because invariably the people that are homicidal, in one study, 98% of them, when I studied 50 homicidal Lyme patients, 49 of them were also suicidal. So the two go together, but not every suicidal person is homicidal.
So
But there's
in our, you know, excuse me, in our clinical approach, you know, we go through a stabilizing period and then we start slowly. And, you know, we're not always 100% successful in stabilizing. And so why we go through a very early startup with programs of modest potency with pulsing, with breaks, is to see if we're going to provoke anything like this. And if we do, then we take a time out and we make adjustments either on the stabilization of the neuropsychiatric system as best we can, or we reduce our introductory treatment program, or we just take a break. But yeah, so this is not at all unexpected. So people that come from outside are given 2 drugs by a doctor that thinks 2 drugs every day is the way to treat this disease. And the patient goes, you know, near insane. You know, we just say, well, no, this has to be a more measured, well thought out approach, sequential approach to therapy. And there has to be adjustments made for the amount of neurotoxicity we're creating, because after all, we're talking about the nervous center. And, you know, that controls the mood, controls everything, your thought process and so forth and so on. Get more and more detached. Your sleep may go south. You may have new headaches. You may have new neurologic pain and so forth. We need to know that. We need to medicate for that, and we need to adjust therapy accordingly.
Dr. Bransfield, this question is for you. We got a few of them about OCD and why you think OCD symptoms happen in Lyme patients, and how do you treat it?
Well, OCD, I think, is different than your anxiety or social anxiety symptoms. OCD seems like it's more an autoimmune symptom. And that's a different part of the immune system rather than an inflammatory related symptom. Okay. So that, and it can be of abrupt onset. We think of the model, what's called PANS or PANDAS, where you get the infection and then you get inflammation, that early response, and then you get that antibody reaction. Now, some of those antibodies then go against the brain. And for instance, we think of the 31, 34 bands. People that have some of these autoimmune symptoms, we might see more reactivity of those bands. And so there can be that abrupt onset of OCD. Now, part of OCD could be the intrusiveness that we spoke about before, but the other parts like the looping. The part of OCD is pervasive doubt. And the opposite of doubt is assurance. So think of OCD like hand washing, that, okay, I wash my hands once, I'm assured that they're clean. But if I'm obsessive, I doubt it, so I want to do it one more time. And now I do it 100 times, hoping that I'll be assured, but I never do. And I'm stuck in that routine. So the doubt circuit is stronger than the assurance circuit. Now, there's a big spectrum of different OCD symptoms and how they show that could be defined in a somewhat different way. But I think there's a lot of autoimmunity with that. But again, it's related to that. And there's a lot of infections, Coxsackie, strep, that go with triggering OCD. Strep was one prototype, but you see it with your Lyme, tick-borne disease, tick-borne complex patients in a certain percent, in a fair percent. And these people invariably did not have it when they were younger, or maybe they had it when they were younger, but it got a lot worse once they acquired the tick-borne disease. It reactivated.
I think everyone wants to know, obviously there are so many psychiatric symptoms, OCD, the anger, the rage, paranoia, anxiety. Do these symptoms go away with treatment? And if they do, where or when in treatment do you typically see them resolve?
Yes, I've seen them go away. Like I did a study, and that's one of the journal articles. And I studied medical students, and the average, And I did my Lyme assessment of like 270 questions. And the
Mhm.
average medical student had 4 symptoms. And the average Lyme patient before they had Lyme had about 4 symptoms. The average Lyme patient that I saw after they had Lyme had 82 symptoms.
Wow.
So the greater the comorbidity, the greater the likelihood of this Lyme tick-borne disease complex. So if you just have panic attacks and nothing else,
Mhm.
maybe you just have panic disorder, maybe there's some other thing causing it other than Lyme. But when you have that much comorbidity, you have to think of something that affects the entire body and the entire brain. It's a multi-system illness. And maybe it could be some other multi-system illness. But this is a multi-system illness. So you get the cognitive, you get the emotional, you get the physical, you get the GI, you get the bladder problems, you get everything. That's how you make the diagnosis. Okay.
Mhm.
And then the trick is, how do all the symptoms fit together, and where do you intervene to untangle that puzzle where you get the most impact for the least intervention?
Mhm.
Treat the critical symptoms and treat the infection in a way that doesn't provoke too strong of Herxheimer reaction that might make someone suicidal or bring out some other Lyme symptoms.
Mhm. We have time for a few more questions, so we're going to hop to the next one, which is, what is the best way to treat depersonalization or derealization? So in a little bit, I'm going to refer to Dr. Bransfield on how to treat that from a medication standpoint, but from a psychotherapy perspective, there's a lot of mindfulness and grounding techniques you can use. But for those who don't know, in very simply put words, depersonalization or derealization is when someone feels detached from themselves, their body, the external world. People often describe feeling like they're floating, they're watching themselves, they're observing themselves, their body or body parts look distorted, or they don't recognize their family members. They feel robotic, they feel emotionally disconnected. So when that's happening, the goal is to bring you back to the present moment, to bring you back to reality. So some of the mindfulness or grounding exercises someone can do, and they're super easy. Anyone can do them. You can go outside and put your feet in the grass. Pay attention to the sensations in your toes. What color is the grass? What do you see outside? What do you smell? What do you hear? You could put an ice cube on your hand or on your arm. Pay attention to what that feels like. You can go into a room, preferably a safe room, and list 10 items that you see in the room and describe them in detail. Or you can count how many circular items do you see in this room. You can try to use all your senses. Go smell something, go taste something. Because if you can hear and see and smell and taste, it will remind you that you're in the present moment, that you're real, that you're in the here and now, and that is the goal. And also mindset is super important. So people get very freaked out, understandably, when this happens. But reminding yourself that this is a symptom of the illness, this is not you going crazy, and it will pass. That's the important thing to remember. People think they're going to be stuck in this mindset, in this state forever, and you're not. It will pass. But Dr. Bransfield, how do you treat that from a medication standpoint?
Okay. Now, occasionally depersonalization could be secondary to, let's say, extreme anxiety like panic attacks.
Mm-hmm.
So then when that's the case, and think of it as a psychological defense mechanism. Let's say you're a prisoner of war, you're being tortured. You can survive by depersonalizing, by detaching, and
Right.
that you treat the reason, and you see it with people that have bad trauma of various sorts. Okay.
Mm-hmm.
Now, if it's not that, if it's just depersonalization, and sometimes I see depersonalization, derealization from head injury. I've seen it from brain tumors or after tumor surgery. Okay. I had a patient like that today. Now, in regard to meds, Lamictal, there was a study with that, lamotrigine, showing it did help depersonalization. I've also used it for derealization, and that does work. I think that's the best treatment. Sometimes benzos or other, generally anti-seizure meds seem to be helpful. Gabapentin, I've seen work. Valium, diazepam, I've seen work with some people. So you have to kind of try, but lamotrigine, Lamictal is usually what we start with, and we work our way down the list. If you have the depersonalization from permanent brain injury or derealization, and derealization is less common in depersonalization, but you do see it. Then a lot of times a person just has to stay on these meds, but sometimes you can gradually reduce it over time. But it is, and I think the things that you're talking about are good strategies to get you more connected. You feel like you're a ghost, like you're like Scrooge in A Christmas Carol, like you're there but not there. It's a weird feeling.
Mm.
And derealization is more Alice in Wonderland, where your surrounding doesn't seem real. The opposite is presence, like command presence, stage presence. When the quarterback walks on a football field or the general walks out, he knows he's there. So you don't feel your presence. It's you're disconnected from your existence.
Mhm.
That's the fourth floor in my mood condo, by the way.
Okay,
And
good.
Dr. J, you've mentioned if it doesn't scare the patient, right, you won't treat it, right? The psychiatric, the kind of
Well, if it-
depersonalization, psychotic symptoms.
That's more with hallucinations,
Okay.
visual or auditory. Derealization scares just about everybody. But with hallucinations, we hear them all the time. And my simple question, I think Dr. Branchfield agrees. And I just say, hey, I've got one question. Does it freak you out? No, I'm kind of getting used to, Uncle Teddy, out of the corner of my eye, or what have you. But if it freaks the patient out, that's destabilizing. And then we'll use one of the, very gently introduce it to one of the atypical antipsychotics. And we generally have lamotrigine on board already, and have already measured drug levels. We may have another neurotropic acting in a different way. So gabapentin and pregabalin, or Lyrica, work by interfering with calcium channels, which are the ions that are escaped and sequenced to activate certain neural pathway, whereas lamotrigine, trileptal, tegretol, zonisamide work by the sodium and potassium channels. So I like to use combinations of either one, and we always use the lowest effective combination, and they are synergistic.
All right, we have time for one final question. I wish we could get to all of them, but unfortunately we're running out of time. So the last question, how common is reactivation versus reinfection? And how do you typically know the difference? Dr. J, what do you think?
Well, reinfection, like Bob said, would be more of an acute situation, I suppose. I don't know that you can really definitively tell the difference. My feeling is that we never eradicate the spirochete. Maybe we eradicate some of the co-infections, the driver being Babesia. Bob knows this is, thinking out of the box, but I mean, we've seen more patients than anybody on the planet, and this is what I believe. I believe Babesia is a driver. So I think that reactivation can be caused by any kind of non-specific stressor, which imbalances the immunologic paradigm, because it's all about the immune system.
Sure.
And as long as you have the components that are capable of, the stealth pathogen cabal, so to speak, if you have all those components in place, you can reactivate easier than if not. And again, it could be a trauma of any stressor of any kind, physical, emotional, lack of sleep, whatever. And so to me, I think that, for example, the bullseye rash is a reactivation phenomenon. It's brought on by memory cells. It's not an initial phase response. It's an amnestic response because it occurs in 2 days. And there's some data to suggest that through cell blister study. So that's not the first rodeo. You get a bullseye rash, that's not your first rodeo with the spirochete. And so once we have these pathogens, I look at it as opportunistic infection, quite honestly. If something distresses the immune system, whether it's COVID vaccine or a slug of steroids or an anthrax vaccination or a series of life stressors that just are, immense and horrendous, if the immune system dips and it dips far enough, then it's playing catch up, and then you have symptomatic illness and a disease which goes straight for the nervous system.
Dr.
think-
Branchfield,
yeah.
yeah, go ahead.
I think when it's early infection, and I would agree. I think the bullseye rash, you're sensitive. Probably you get the bullseye rash with your second infection, not your first, because you're sensitized. Just like a bee sting, you get sensitized when you get the second bee sting, not the first. And I think, you know, is it, let's say, if it starts with the musculoskeletal aches and pains and those early symptoms, then it may be a reinfection, fever, a sudden fever, that type of thing that makes you think of recent infection. But if you instead get the late stage symptoms reemerge, then that's reactivation. A lot of times you'd see it, let's say after a car accident, after childbirth, after trauma, after stress, sleep deprivation. So when you get the depression, panic attacks, anxiety, the suicidality, those are late stage symptoms. That's reactivation, not reinfection. Although maybe you had a reinfection that triggered reactivation of a latent infection
Yeah, I mean,
was
yeah.
already there. And it may be not just tick-borne infections, but opportunistic co-infections that are in your microbiome, your pathobiome.
Yeah.
And they may be viruses that are opportunistic,
Yeah,
that
it
get
doesn't have to
reactivated.
be. Doesn't have to
You
be.
know, I think it's a whole symphony of pathology that gets triggered. And also back to the idea of what we were talking about before, like with my example of 82 symptoms. Do you treat 82 symptoms? No. You treat the worst ones and you work your way down a list. And if depersonalization or whatever is low on the list, you don't treat it if it doesn't bother someone. You treat what keeps someone entrapped into disease progression or disease perpetuation the most, and not the lesser symptoms that are of lesser significance. And if you treat the critical symptoms, then often the other things can dissipate.
I totally agree. That's good. Well said, Bob.
All right, we are out of time, everyone, but I thank you for tuning in, and thank you as always for your awesome questions. And look out for Dr. Bransfield's studies. We're going to publish those soon. I mean, we're going to post those soon. And Dr. Bransfield, we cannot thank you enough for taking the time and joining us today. I know everyone appreciates it, and everyone was really excited to have you today. So thank you so much.
Okay. And thank you for doing this. It really is a good thing. Education is our best tool. Education and research. And a lot of times I'll go to some meeting somewheres and somebody comes up and says, "Thank you, you saved my life." And I say, "Well, that's nice to know, but who are you?" And they saw one of these videos or something like that, and then they learned from that, and they went and they pursued the accurate treatment. And it makes a difference when you do this. And doing the support groups, that's critical with the family dynamics, because that's a big issue. So keep it up. Educate, educate, educate. Okay.
Well, we try to educate, and we try to be professional. We try to not be political. And it's, again, I just want to reiterate, what an honor to have Dr. Robert Bransfield on our Zoom 1 hour live stream. What a tremendous honor. I hope we can do this again in a few weeks or months.
All right. Thank you, everyone. See you next time.
Thank you, Bob.
Bye. Thanks, Sam.
Bye.